Hello everybody, my name is Mary Kennedy and I'm a PhD researcher and social worker based in the School of Social Work and Social Policy at Trinity College Dublin. My virtual presentation today will focus on the strength and differences between health and social care interpretations and implementations of the adverse childhood experiences evidence base. To start off, I'm going to talk about ACEs in Wales. For me as a PhD researcher, submitting an abstract to a Welsh conference to talk about ACEs was a dream. That being because talking to a Welsh audience about ACEs is like... Unlike other countries, my own for example, I do not have to spend my entire 10-minute time frame explaining what ACEs are or revisiting the seminal ACE study in 1998 by Dr. Vincent Folletti and his colleagues in San Diego, California. Wales is far too advanced for that basic knowledge. In fact, Wales is so advanced in understanding and recognising ACEs that you've taken them into consideration in your policies and legislation. Researchers in Wales are significant contributors to the ACEs evidence base. Welsh researchers have not only established the prevalence of ACEs within your population, but have also progressed to explore a range of important ACE-related issues. Not only that, but Wales has an ACE support hub, whose primary function is to support Wales in becoming a leader in both tackling and preventing ACEs. So to be honest, finding an appropriate ACE-related topic that would not bore an ACE-aware audience such as yourself was a challenge. But I think I found something that might be of interest to you. So let's get started. To identify the strength and differences, it's important that I provide you with some context about the level of research interest in ACEs from both health and social care settings. To do this, I want to show you the results of a literature search that I completed for the purpose of this presentation. I completed this search on my university's search engine called Stella. Stella has access to 502 research databases. For my literature search, I ticked the research refinements for peer-reviewed academic journal articles. My search involved key terms such as adverse childhood experiences, ACE and ACEs, followed by individual health and social care terms and professions. These searches then provided me with the results. This table represents the results from this literature search. This list does not represent all professions, but you will see from this table that ACEs have been researched to varying degrees by a range of health and social care professionals. Now that we understand that researchers in both sectors are interested in ACEs, let's explore the differences in their studies. Please be mindful that due to time constraints, the following examples mentioned are not representative of the expanse of ACE interest in either sector. ACEs research in healthcare has largely been undertaken with a singular discipline focus. Occupational therapy have examined self-regulation as a key factor in protection against the harmful effects of ACEs and the critical role of OTs. Doctors have examined physicians' knowledge and practices regarding screening adult patients for ACEs. Paediatric psychologists have investigated the role of wellness navigators in addressing ACEs by promoting equity and resilience in clinical settings. And nursing have interestingly explored the integration of education about ACEs across the nursing curriculum. Similarly, ACEs research in social care has largely been discipline specific, but there are some examples of researchers exploring a range of disciplines in their studies. Child and family professionals and policymakers' perspectives on public health approaches to address ACEs have been examined. The experiences of health visitors, family advocates, professionals working with children and young people impacted by substance misuse, and local authority, family and wellbeing practitioners who are trained to routinely inquire about ACEs have also been explored. Social work has explored the need to consider ACEs when reimagining the organisation and practice of social work with children and families. And lastly, a pilot study on a hope-infused, trauma-informed approach to help families understand their past and focus on their future used by home visitors in the USA was examined. I am entering my third year of my PhD study examining how routine implementation of the ACE survey is informing service provision within a social care organisation. Due to the nature of my study, I have spent the best part of the last 2 years comparing research about ACEs in both health and social care sectors. Having done that, I can say with confidence that both health and social care interpretations and implementations of the ACEs evidence base differ. How do they differ exactly, you might ask, when it comes to ACE interpretation and implementation? Well, healthcare interpretations and implementations differ because healthcare researchers and professionals treat the health-related negative outcomes of ACEs. They help to reduce symptoms and change behaviours. They are familiar with epidemiological research, and they know how to use this data to advocate for and argue for changes and improvements at public health policy level. They are very familiar with the negative impact of ACEs on individual health, and they recognise the impact of ACEs on societal wellbeing outcomes. And interestingly, clinical settings represent the majority of settings where ACEs research has been undertaken so far. Although there are differences, I think it's important to draw your attention to some of the similarities before progressing on to social care interpretations and implementations. These similarities include evidence that both sectors are focusing on becoming trauma aware. Both have professionals that work in clinical and community settings. Both understand that social determinants of health can exacerbate negative ACE outcomes. Social determinants of health are the conditions in which people are born, grow, live, work, and age. These circumstances are shaped by the distribution of money, power, and resources at global, national, and local levels. The social determinants are mostly responsible for health inequalities. The similarities are also that they both have to justify their service provision and account for spending relating to ACE prevention and response. And lastly, both advocate to mitigate the impact of negative outcomes associated with ACEs. Social care interpretations and implementations of the ACEs evidence base differ to healthcare because the use of resilience-based approaches is more evident in social care. They are able to navigate social welfare systems. They help to deal with the impact of coping mechanisms and negative ACE-related outcomes in everyday life. They respond to the negative impact of social determinants of health every day. They also possess a vast amount of secondary data relating to how social determinants of health exacerbate the systemic negative impact of ACEs. They take a systemic view in addressing negative outcomes associated with ACEs. They are predominantly community-based, which means that they can observe living conditions and functioning firsthand in a person's home. Having different interpretations and implementations of the ACEs evidence base is not necessarily a bad thing. There could very well be potential for identifying, intervening, and responding to ACEs in this diversity. What is the strength in these differences? Poverty has consistently been identified in the evidence base as an exacerbating factor in negative outcomes associated with ACEs. This image represents the crossover cycle that happens when an individual's social determinants of health impact on both health and social care responses to ACEs. No matter what starting point you choose on this diagram, there are examples of this impact on both health and social care settings. For example, delayed discharges from inpatient care because of poor social support systems, or difficulty accessing social care services because of homelessness or insecure housing, or for being transient. The difficulty with the ACEs evidence base is that valuable research is undertaken separately in healthcare settings or in social care settings, never collectively or collaboratively at the same time. Both sectors have expert knowledge, but from their own perspective. To advance ACE intervention and prevention to ensure social determinants of health for all, there is a need to combine both the health and social care ACEs evidence base. Bringing together health knowledge about effectively using epidemiological data with social care knowledge about welfare and community systems could result in powerful evidence to improve funding for both sectors that would be incredibly difficult to challenge. As well as that, combining healthcare knowledge about the impact of not ensuring social determinants of health on societal well-being alongside social care knowledge about the impact of ACEs and not ensuring the social determinants of health on broader systems within society could result in significant improvements for those impacted by the negative outcomes associated with ACEs. The knowledge in both may be diverse, but both health and social care sectors want the same thing. They just have to create pathways to use their data collaboratively to meet this combined objective. Bibliography. Where did I get this information from? Remember, you will have access to this video after, so you will be able to rewind and pause. So due to time constraints, I'm going to move on. Please feel free to contact me if you have any questions. My contact information is below. I really hope that you've enjoyed this virtual presentation and that you've learned some new information about the ACEs evidence base. Enjoy the rest of your conference, and thank you for your time.